Great. Thank you very much. And I want to thank the Seattle Science Foundation again for the opportunity to speak and to share these results. I'm excited to be here today and especially to be surrounded by incredible faculty. I really want to thank Dr. Lin for his talk. It was a very thoughtful approach to what we're doing posteriorly in our constructs and not neglecting the physiology of bone, but taking into account material properties and their importance in either helping or hurting natural bone physiology. His talk actually dovetails perfectly into what we're going to discuss now, which is moving to the anterior column of the spine and seeing if there's a role for approaches to anterior column reconstruction that can aid us in encouraging fusion without creating too stiff a construct that we would end up with stress shielding, et cetera, but also hopefully solve those problems that we've just discussed posteriorly with rod breakage, et cetera. And so it's interesting for me to sort of take these two different topics hand in hand and see how they dovetail together. And it's my hope that as we gather more knowledge in this realm of spine surgery, that we come up with some solutions that maybe we haven't thought of previously. And so in disclosure, I am a primary investigator for the study that I'm about to discuss, the COMPASS study, and that our institution receives research funding for that. And then these are some of the other disclosures that don't necessarily correspond to the talk itself. And so I'm a big believer in anterior column support as an adjunct to deformity correction. And my interest in a personalized approach to the interbody space was really born out of a patient as is represented right here, in which we had a very well done surgery done in the past. I would argue that the surgeon that handled the L2 to 5 fusion paid close attention to recreating lumbar lordosis. My suspicion is that they had very good diagnostic acumen and that they approached this patient in such a way that they were addressing the patient's pathology. And unfortunately, by the time that they came to my clinic, they were several years out from the index surgical intervention. They reported having done well for quite some time afterwards, but then they developed this problem. And so the prior fusion is from L2 to 5, and we can see that the patient is tilting fairly dramatically to the left at L5S1. And if we look at the CT scan all the way on the right-hand side, we can see that the patient has bony loss on the superior plate of S1. If this were the most difficult problem, this would be a much easier patient, I think. But if we then come up to the more cephalad aspect of the spine at L1-2, where we see an erosion of the original surgeon's fixation into that L1 disc space and relatively significant bony destruction. And these are patients that I've encountered a fair amount in my practice. And while I believe that the lower lumbar levels, both L4-5 and L5S1, especially with anterior column reconstruction, can be used very powerfully for sagittal balance restoration, it's really our upper levels, so in this case L1-2, that contribute quite powerfully to restoration of coronal alignment. And so when I look at this patient, traditionally this is a patient that at the L1-2 segment, I would want some type of interbody fixation. And of course, our possible approaches are probably twofold. One, we could approach it from the back. Some people may consider a corpectomy because of the bony loss associated with this patient. Others may try to put an eccentrically placed transforaminal lumbar interbody fusion or other posterior approach to the back, keeping in mind that we're sort of around the conus. My more traditional approach to this would probably be a retropleural approach, in which I would do a lateral approach to the spine and be able to address this issue. But if I simply take an implant out of the implant carrier, most of these are rectangular shaped, I'm going to have a hard time accounting for the bony loss associated with this patient's pathology. And there was a time in which I would ask my rep to open up the coronally tapered tray, and we'd spend a little bit of time on the back table going through a number of sizes and heights, and tapered to the left, tapered to the right, a certain degree of lordosis, et cetera, and like finding the perfect Lego. Eventually we'd pull it out of there and say, this is the one. I found these to be somewhat dissatisfying. And so when I was looking at new approaches to the anterior column reconstruction, this was the problem that I had foremost in my mind. And so is there a way that I can account for this significant bony loss? And here's a representation of this same patient in which we've taken the CT scan, we've digitized it. This allows us then to segmentalize these problem segments, and we can put the segmented segments into the ideal patient alignment and then hopefully create something that can fill that space. So back to rooting through the coronally tapered interbody devices, never once did I find one that would look like the one on the left, for example, for that L1-2 segment. Instead, this is something that's been designed up through modern additive production technologies in which this is perfectly designed for this particular patient. If we see the anterior lumbar interbody diffusion device used at L5-S1, it also accounts for the bony loss, which I would argue, again, was less significant at the L5-S1 segment. And so this kind of sparked my initial interest in rethinking the anterior column and taking an approach in which we could maybe adopt a patient-specific solution for that anterior column. If you were to go and look at where this technology was born from, most of us know that the interbody space is not a perfect rectangle. Even in non-pathologic patients, we know that there's concavities and convexities, and that the topographic map of an end plate is relatively complex. And so if we were to subtract the idea that this is a technology that's superior in patients with bony loss, and just look at our typical patient, the typical, say, degenerative patient, not even generalized to the deformity, and say, what are our issues? On the left side of this somewhat busy slide, and I want to credit Dr. Christopher Ames, who put this particular slide together and was able to capture a lot of my sentiment as I was looking at these technologies, but some of the complications we deal with and the causes of these complications, which are listed in the center. And then looking specifically at a patient-specific approach in which we topographically map out the end plates of the patient, that we take into account the pathologic deformity or degenerative issues that that patient is dealing with, and then create through additive technologies a interbody that can then support the space that we're hoping to correct surgically. What are the potential benefits from that? And when the FDA was specifically looking at this, they allowed the quotation here, likely to provide for a more effective treatment versus standard care, which allowed them to then change reimbursement strategies for CMS patients specifically in regards to these devices. But the term likely should not be very satisfying to a lot of us in this room, right? We want to know through hard data, not just biomechanical data, whether this makes a difference. So on the right-hand side, though, we see the biomechanical data. This was data that was available around 2020. My first case was early in 2021, in which I wanted to see if these technologies would aid my ability to take care specifically of the deformity population. But then if we look at the differences here, that in answer to Dr. Lin's question, for example, we see 28% decrease in posterior rod stress just by having better end plate coverage. And this is in a patient that maybe doesn't have those bony erosions, right? That we're just trying to match the interbody space to their anatomical interbody space. And we get 50x increase in our contact area, and our next slide is going to get into this a little bit more. 30x reduction in stress concentration. This was one of my frustrations in the approach to these patients, is that even if I'm able to get a lateral interbody, for example, from cortical margin to cortical margin, we know that subsidence can occur over time. And one of my greatest goals in approaching these surgical patients is decompression, and often we achieve adequate decompression through indirect means. Well, there are several studies that address the loss of indirect decompression with subsidence, and so if we're stress loading the interbody space, then we may be setting ourselves up for future failure in these patients. And then, so reduce stress potentially inside the adjacent discs and facets, and I think a lot of that gets back to what Dr. Lin already taught us, is that when we're relying on a posterior-only approach to the spine, whereas the center of gravity coming through the anterior column, if we can offload that posterior column, then we see quite a bit less stress across the adjacent segments as well. And so this is a good depiction. Again, this is biomechanically showing in which we see sort of a typical off-the-shelf implant as opposed to the anatomical interface with something that is designed with the patient-specific inner body space in mind. And of course, the green, the yellow, the red, that is indicative of point loading. The blue segments show less contact stress of the device within that inner body space. And so the Compass Registry is looking at a number of these devices, whether they be used through an anterior approach, a lateral approach, or even a TLIF, all posterior approach. And we include essentially both deformity and degenerative patients. We're cleared for up to 350 subjects, of which we've already enrolled over 330 in the last 2 years or so. And then following these patients for 6 weeks, 6 months, 12 months, and 24 months post-op. And it'll be my suspicion that we'll extend that somewhat beyond that. Our primary endpoints are looking at the radiographic outcomes associated with these patients and any adverse events that might be associated with either the surgery or the implant itself. And then our secondary endpoints looking at patient-reported outcomes. So the data that I'm about to present is based on this prospectively gathered data and our retrospective review of these data points that are available to us. Here's a representation of our study sites. Again, 16 centers. We'll notice there's a massive void in the Midwest, and we're hoping to address that. But 22 surgeons total and 16 different centers that are working on this. And for this particular study and this particular data, we wanted to be able to assess the severity of deformity. And it's interesting as we look at the different modalities and mechanisms in which we can do this. We chose to look at the SRS Schwab sagittal alignment modifiers as far as classifying our deformity patients, which we extracted from this data set of the 330 patients, and wanted to be able to classify their severity. Of the 125 some patients that qualified as deformity patients out of the study group, we had over 60 of those patients with a complete data set available for us for this particular study, and then classified these patients according to mild, moderate, or severe according to the SRS Schwab. Now, what's interesting about this particular mechanism in assessing severity of deformity is that it's very good at assessing sagittal imbalance and does not really take well into account coronal imbalance. You'll actually see that with some of the patients. But looking at specific radiographic parameters, including the differential between pelvic incidence and lumbar lordosis, the pelvic tilt, and the global alignment, we're able to radiographically assess each of these patients and put them into a certain box as far as severity of their deformity. And again, keeping in mind that this is primarily sagittal. So if we look at these three different radiographic mechanisms and we compare and contrast them, looking at PI versus our lumbar lordosis, you can see that our patients on average could be categorized as a severe deformity preoperatively, and that postoperatively we're able to reduce the study group as a whole to down to below moderate deformity or within the mild deformity classification. Whereas we did not have a significant impact in pelvic tilt. You can see that the majority of patients preoperatively were considered severe and that the majority of patients postoperatively were also considered severe. And what's interesting to me to compare these two different data sets is that our goal really was most encapsulated by maximizing our benefit through realignment of the pelvic incidence and lumbar lordosis. And you can see that we were very effective in accomplishing the goal in this regard. If we looked at global alignment, as is signified by our T1PA, we started with an average of severe deformity, and as an average group, we're able to reduce our patients into the moderate deformity category. And again, this is based on 67 patients, 9 centers with a median follow-up of 15 months. So we were able to take greater than 38% of the patients improved from a pre-op moderate to severe deformity down to a post-op mild or none deformity. What's interesting about this is I think that the data set is somewhat skewed by patients with primarily a coronal deformity, because a lot of those patients would fall into the mild SRS Schwab classification. And if you were to look at their procedures both pre and post-operatively, we can see a dramatic improvement in their coronal deformity, even when they did not have necessarily a pre-existing sagittal imbalance issue, and that our greatest ability to improve is in the mismatch between pelvic incidence and lumbar lordosis, and we saw a mean increase of 10 degrees in lumbar lordosis with the treated patients. And so then the question becomes, well, is this really the inner body that's doing this work, or is it the surgeon with their expert carpentry, right? We've addressed that question as well. And we divided these up, looking at levels that were treated with a personalized inner body versus levels that were not. And if you can see preoperatively, about 14.1 degrees of the correction that the original preoperative problems were only corrected by about 2 degrees through our carpentry, and that through the levels that we had an inner body to recreate lumbar lordosis, we saw a mean increase in almost 8 degrees in those segments. And so looking at this data set also, we looked at our adverse events, and the majority of these adverse events were perioperative medical complications. We had one patient in this data set return to the operating room for PJK, and this compares very favorably to published literature in which we see upwards of 10% for the same follow-up time for this particular patient population. And so what we've learned by looking at this group of patients, a subset of those included in the COMPASS trial, is that we are able to directly impact lordosis in a favorable way for the patient, reducing the PI-LL mismatch, and that it seems to contribute favorably to reproducing overall sagittal alignment correction, and that we have low rates of acute and short-term mechanical complications and implant-related adverse events, with more to follow. So if we go back to our original patient, in which we were able to construct a patient-specific approach, and through really only anterior column reconstruction at 2 levels, we see on the left-hand side, obviously, the presentation in the coronal plane. What's interesting is that this particular patient probably would have been classified as moderate by the SRS Schwab, but when you take into account the coronal issues, then I think all of us would agree that this is maybe a little bit more than moderate as far as the severity of deformity. But we took an intraoperative CT scan, meaning between the 2 stages. I typically do the anterior column reconstruction first, followed by the posterior stabilization as a second stage. And we can actually see in that CT scan the topography of the inner body device and how it matches up with the patient's pathologic topography and conveys our desire to improve both sagittal and coronal imbalances. And then, of course, with the final outcome. So this is a fairly common case example for myself. I'll just kind of breeze through this a little bit more quickly, but we see some of the parameters associated with this patient's deformity. We're able to develop a plan in which I was planning anterior column reconstruction with off-the-shelf devices at L4-S1, our anterior lumbar interbody fusion to restore sagittal alignment, and then to correct her coronal malalignment, personalized interbody from L1 to L4 through a lateral approach. And that was our plan. After our anterior column reconstruction, we can actually see through the CT scout view the power of anterior column reconstruction in correcting both coronal and sagittal deformity, and of course bringing the patient, this is again a CT scan between those, looking at the conformity of the inner body device to the pathology, with a minimally invasive approach to posterior stabilization, and then our final radiographic outcome for this particular patient, in which we ended up doing T4 to ilium with excellent restoration in the patient's both sagittal and coronal imbalance, that I owe a lot to our preoperative planning and our ability to execute that plan on the day of surgery to create hopefully better outcomes for our patients. That's it.
Great talk, Roland. Very interesting.
Thank you.
Can you just maybe just go into a little more detail how you decide how much correction you can get through your cage? For example, the first case you showed, there was a lot of coronal plane deformity at L5-S1. Do you aim for overcorrection of that joint? Do you want to tilt it over the other side? And how is it done through a 3D model to recreate what you're trying to achieve?
So our 3D modeling is all digital. What's been interesting to me actually is interacting with patients in this regard, because some of those plans that I showed are just screen captures off of an app that I have available to me, that I use that app to interact with the engineers who are helping to sort of aid me in the creation of this personalized approach. approach. But really what we're utilizing data-wise is the data that's available to us largely through the ISSSG and other study groups, and saying this is the optimal approach to these patients. So for example, down low with our anterior lumbar interbody fusions from L4 to S1, we're trying to catch that sort of 38-degree holy grail. And then we look at everything up above that and say, okay, for age match realignment goals, what do we need to achieve as far as lumbar lordosis, say, through a lateral approach to L1 to L4? And I tend to look at the patient rather than on a disc-by-disc basis. I look at them as my sagittal, my global realignment. And so generally, I would argue that we probably err on the side of undercorrection, both from a lumbar lordosis standpoint, and this is my personal approach to these patients, as well as sagittal realignment, because I do believe that our posterior stabilization goes a long way for derotation, allows us to take advantage of that carpentry, et cetera. And sadly, I've seen with overcorrection that I think that leads to a number of issues as well. Not only does it lead to proximal junctional kyphosis, but I think especially men have a hard time with a very aggressive correction in which we restore disc space heights and cause anterior column lengthening. In those patients, I would prefer to get a good second base hit than a home run a lot of times as far as overcorrecting. So I have a tendency to undercorrect both my lumbar lordosis and my sagittal realignment. And then typically with the posterior stabilization, we tend to get right in the ballpark of what I've been trying to accomplish with them. But that's a great question. If you do too much, I've seen some complications associated with that.
And so what does overcorrection mean?
Yeah, and again, it gets back to whether you're a fan of age match parameters or not. For me, an overcorrection is simply probably doing too much than what we were planning to do in the first place, right? And a lot of that gets back to the idea of carpentry. So, for example, if I stick a very large interbody device at L2-3, regardless of the lordosis of that interbody device, I may overcorrect them from a sagittal perspective. And so what I'm looking at is the global parameters and looking whether I've created a sway back deformity in these patients, et cetera. I would prefer the majority of my older patients to have some positive sagittal balance post-operatively. And I think early on in my experience with this, I was so impressed by the power of the interbody device that I had a tendency to go the other way and overcorrect those patients. So there's definitely a learning curve associated with it. Yeah, please.
Ken, I had a question. How have you shifted your disc prep kind of routine as you have gone to these implants? Because I've experienced the fact that you do a lot of carpentry to make those end plates parallel, and but now that you have these implants that are made to the topography, then your disc prep is going to be a little bit different. So you got to kind of preserve those natural incongruencies into the disc space. So how have you shifted how you do disc prep and preparation of the end plates?
Yeah, that's a great question. I would argue that most of what's changed in me is the soft tissue releases, and that I take much more time to mobilize these segments and less time just using brute force to get, say, a trial into a space that it shouldn't be in, because we've all seen subsidence of our 11 millimeter trials on a lateral approach, and we sit there and go, man, while it may be perfect for the patient that we're looking at for an out-of-the-box solution, the problem is that patient may have subsidence. We may lose our indirect decompression. So to be honest, I typically under trial now. I'll spend more time releasing the annulus itself. I'll make sure that the disc space itself is reasonably mobile, and then I under trial, and I'll then put the final device in with very little sharp debridement of the end plates themselves, keeping in mind that the device is a porous titanium device, and I think it goes a reasonably long way to help prepare the disc space. But I still use a push-pull. I use a rasp. I just don't push as hard as I used to, I think, is the biggest issue, is you want to preserve the natural topography as best as possible. So that's an amazing question. The best thing is just not over-trialing. Yeah.
Great talk. So similar in vein as that question, sometimes when we're trialing up, you see neuromonitoring changes due to the distraction and nerve retention. And when you've planned a personalized interbody, if all of a sudden you're faced with not being able to put that same height in, how does that change your intraoperative decision making?
Yeah, so the engineering of this is that we get 3 different interbodies. So there's a planned interbody, there's a minus size, and there's a plus size, right? And so if I've done too much soft tissue work and get too big a release, right, maybe the exact opposite of what you're talking about is going to happen, in which it's sloppy within the disc space, and that's also worrisome. What I found out, again, back to this idea of the learning curve, was that my templated device went in very seldom, and that my minus devices were going in very frequently. And it was just for the exact reason that you're talking about, that I was more concerned about the neurologic sanctity, et cetera. And so then when I went back with the engineers, I went back and said, okay, now I want all of my minus devices to be the templated device, so that on top of that, now I have a plus device and a minus device. And to be honest, the neat thing about that is that, again, you can show the patient after the surgery, this is the device that went in at L1-2, because I've got 2 leftover devices that were unused, right? So not only do they get this hopefully reasonably good surgery, they get a souvenir afterwards.
I can certainly see how the patients would appreciate that. What about the Canadian government? Would they also appreciate all those souvenirs?
I think that's an amazing question, right? So we always have to look at the cost efficiency, and that's where actually, that's the whole purpose of the registry, is to sit there and say, are we providing a difference? And in the United States, there's been this NTAP, which is an extra reimbursement for CMS patients, right? That's in existence for several years after a new device comes out on the market. And then the interesting thing is that then we have to justify the cost of those devices or change the reimbursement structure associated with those devices to continue with longevity with the device that we've decided is worthwhile. And so I sort of applaud the company in this regard by collecting this data, because this data can be very scary to collect, right? You sit there and say, man, I hope that this proves that this is useful to do. But I work in an organization now that's very different than most of the typical organizations. I work in a surgeon-owned hospital where the bottom line is super important, right? And so I tell every single surgeon when they're looking at a new technology is, if it doesn't fit the bottom line, you're not going to be able to utilize it. And so the Canadian government obviously has already agreed upon price structures for each of these technologies. And then you just have to work with the company and sit there and say, hey, we believe in this device. These are the parameters that you have to work with, and let the CFO of the company work through the creativity on the monetary side to make sure that it works for your organization.
Awesome. Thank you so much.
Quick question. So from the planning standpoint to kind of delivery and undergoing the procedure, how far apart are they? Is it 6 weeks? Is it
Now, about 30 days for the plan to actually be sort of approved, and for the devices to be available in the operating room. So, and again, you have to look at your own practice. So in my practice, my deformity backup is approximately 4 to 6 months, right? So 30 days, no big deal. The patients can handle that in stride. This is not something that you're going to ask them to whip up really quick in the trauma bay because you have a traumatic issue with bony loss, et cetera, et cetera. But that's a great question. 30 days.
Thank you so much.
Thank you.
So next we're going to be going over to Dr. Islam.